Hello, hello everyone. Good morning, good afternoon, good evening, depending on your country. So we are very pleased to welcome you again to this webinar in IRCAD. I'm currently staying in IRCAD, France. You see in my back a view of Strasbourg. This is a webinar that will be focused on left colectomy this time. As you can remember, we did it on the right colectomy, and you still have access to this webinar on the web search website. So if you're interested in looking at this first webinar, it's up to you. Today, the focus is on left colectomy. We have very nice speakers with us. We're trying to cover the most practical aspect of this procedure, looking at the technical details, some new technologies that increase the safety of the operation, etc. So this is a quite interesting topic, and we hope that you will enjoy that. The process of this webinar will be this one. So we will have the speaker giving the talk. And after that, we'll have some ideas of the aspect that was covered during the lecture by response to a survey that was organized by our moderators in the back room. So we'll give you an idea a little bit of the common and current practice of the different surgeons all over the world. And we will do that for each of this lecture. And after this review, you will be able to communicate with us by question, or you can even talk if you want. And again, our moderators in the back room will give you access to the platform to ask your question to the different speakers. So we try to maintain this interactivity, and we hope that you will use this possibility. So my pleasure to introduce the first speaker is Salvador Morales from Spain, well known in the laparoscopic world, president of the EAS, very good partner of our IRCAD. He's used to come several times here in IRCAD doing live demo. He's a brilliant surgeon, and it's again a very, very big pleasure to have him sharing his experience with us for the first lecture. So thank you, Salva.
Thank you, Bernard. As always, it's a real pleasure to be with you and to be with all the participants and to collaborate with the IRCAD. It's always a big pleasure to see that the IRCAD keep moving even during these times, these difficult times. And so for me, it's always a pleasure. I would love to be there with you, sharing our time, but you know, this is what we have today, and we have to get used to this so far, and we have to continue with our educating program, because I think it's important for all the surgeons around the world. So they gave me this topic to talk about the left column sigmoid resection, and the title that they gave me was the surgical principle and anatomy. The first thing I would like to tell you, let me move this out of my screen. The first thing I would like to let you know is that colorectal surgery, or any surgery at all, there is a important links between surgical principles and anatomy. I have to tell you that I'm very excited to read every paper that comes out about anatomy. I think learning anatomy, you learn today to do a better surgeon. Beside that, when I perform any procedure, I'm very, looking for my anatomic landmark to understand what's going on and to understand what is the variation of the anatomy. And these, by getting to know all these variation, at the end, you become a better surgeon. So I think that any surgical principle of any procedure, and especially in open and laparoscopic surgery, but in laparoscopy, the good thing is that you are able to see better what you have inside the body of our patients, and understanding the anatomy, it will make you a better surgeon. So I'm going to run during this line the basic surgical principles of a surgical procedure, basically on the left colon resection. And I'm going to link different aspects of this surgical principle to the anatomy and what you need to know to understand what you're doing. Of course, I'm going to talk first about trocar position, and this is very important. And I have to tell you that every time I have a lecture on this surgical principle, I have people in the audience with the iPhone making picture, and the area, the part of my lecture that there is more people taking picture is about trocar position, because there is a lot of variation from one surgeon to another. And especially when one surgeon is going to start doing a surgery, they really want to know where to place the trocar, because this is very important. If you place the trocar in the wrong place, then you ruin your procedure. So this is very important. For my left procedure, even that I've done a lot of single port surgery through the umbilicus, I like to do, if I am standing multi-port surgery, I like to place the trocar outside the umbilicus. And the reason why I place the trocar is because the aorta is right behind the umbilicus. And if you place the trocar over the aorta, you are going to have the origin of the vessels right there. So it's better to control everything from one side to be able to control with this 30 millimeter trocar the origin of each vessels and to control the whole area of the left column to perform a proper resection. So this is the reason why I like to move out of the umbilical. If you place your trocar here, you're going to be over the aorta, and you're going to have sometimes difficulties to place, to understand the anatomy and to perform a proper surgery. So this is normally my position. I place the trocar here. This is going to be my right hand. This is going to be my left hand, and this is going to be an assistant trocar to make traction and to expose the surgical field. So I'm going to be working from the right side of the patient. My assistant is going to be in my right side, and I'm going to have my two hands working in this area. So I want to make a triangle and be able to properly perform the surgery. But if I talk about left colon resection or sigmoid resection, one of the points, and I'm going to first talk about this, is that I also like to control the splenic flexure. And even if I'm doing a sigmoid resection, I'm always going to mobilize the splenic flexure. At the beginning, when I was doing this, in order to save trocar, I was placing my trocar, my optic here in the blue circle, and work with my right hand in the red spot and with my left hand in the gray one. But after a while, I realized that it didn't make any sense, and it was worthy to place an extra trocar in the epigastric. So the optic is going to be here in the same place. By what is my left hand to work on the sigmoid, it's going to be my right hand to work on the splenic flexure. And the extra trocar in the epigastric is going to be the one running my left hand. So always at the end of the procedure, I'm going to remove the specimen through a fan steel incision, because from the anatomical point of view, this incision have the chance to have less incisional hernias, and it will be better for the patient in the future. Regarding the trocar in the right fossa, that is going to be at 12, you have to remember that from an anatomical point of view, this trocar is going to be placed in an area where the epigastric, the origin of the epigastric vessels, and sometimes there is an extra branches around. So you see that you have to be right in the middle to avoid any injury of these epigastric vessels. People think that to control the epigastric vessel, the best way is to trans-illuminate through the abdomen with the optic. But this is not true. What you're going to see most of the time is the subcutaneous vessels. If you want to control properly, what you have to do is to turn the 30-degree camera and be able to see from inside the epigastric vessels. So while with this vision, you're able to place your trocar right here and avoid an injury of this trocar. And this is important to start the procedure, because if you start breathing, it's really going to ruin your procedure with blood everywhere. But always remember that if you have a skinny patient and you don't want to place a 12-millimeter trocar that the patient is going to feel in the postoperative period, a good alternative for a left colon resection, a sigmoid resection, is to place a 5-millimeter trocar here and to use the 12, where the incision is going to be at the end of the procedure, so you can transect the colon through this trocar, and you can avoid the problem of using a 12-millimeter trocar here, avoiding giving less chance to have an epigastric injury and to have less pain in the postoperative period. But always, from the anatomical point of view, you can have many problems in obese patients. And in these patients, what I do usually is to introduce a gauze inside the abdomen and make traction with this trocar that you use for the splenic flexure mobilization. You use this trocar to remove and to retract the bowel. And also, in case you need it in a very obese patient, you can use this extra trocar again in the funny steel incision to place another trocar with another gauze to make traction of the small bowel to be able to identify properly the origin of the AMI. So I know this is going to be covered by our Italian friends, but regarding the splenic flexure, I have to tell you that even if I do a sigmoid resection, one of the principles of my procedure will be always to mobilize the splenic flexure. I cannot understand a sigmoid resection without mobilization of the splenic flexure. I can tell you that in my last 500 procedure, only in one case, I didn't mobilize the splenic flexure. In the rest of them, I always do it. And when you see this video, it's difficult to understand performing a non-tension anastomosis without mobilization of the splenic flexure. And that's the reason why I always do it. From the anatomical point of view, it's important to see that if you do a partial mobilization of the splenic flexure, based on this study in cadaver, you get an extra 10 centimeter of column to perform the anastomosis without tension. But if you do a full mobilization, the way I always do it, even in a sigmoid resection, you get a 28 centimeter of column to perform the anastomosis without tension. But it's not just a question of tension, it's a question of full mobilization to feel more comfortable during surgery. And this is the way I do it. The way I do it is I usually perform this splenic flexure mobilization through a window that I made underneath the inferior mesenteric vein. This is where I make this mobilization, and this is where I start the surgery by performing this medial mobilization. I think this is important, not only for the mobilization, also to transect the inferior mesenteric vein at the origin of the pancreas to guarantee that the length of the colon is enough to perform non-tension anastomosis. So this is the way I do it. We will see it later with our Italian colleague, but you see how we look for this origin of the vessel to transect it to guarantee that the colon mobilized reach properly the pelvis to perform a non-tension anastomosis. And this is what I show you. By transecting this inferior mesenteric vein in the origin, you preserve this arcade that maintain the flow of the blood coming back. And from the anatomical point of view, I prefer to transect it right here than transecting in some other area. So, but it's important to manipulate the colon in the proper way so you maintain this arcade and guarantee that this arcade is preserved. And that's the reason why I like to go to the origin to avoid a lesion and injury of this arcade and have any problem at the end of the procedure. So, but it's not a question, only a question of tension. It's a question of that I like to do for different reason and also anatomical reason aside to end anastomosis, and I need an extra column to perform any sigmoid resection, and I will show you later. Next surgical principle is where to transect the inferior mesenteric artery. That means performing a high tie right in the origin of the artery or a low tie by preserving the left colic artery. What there is in the literature regarding this, analyzing the perfusion of the colon based on if you transect the inferior mesenteric artery a high or a low level, there is some data from this comparison of different paper, and basically the final conclusion of this paper is there is no significant difference if you do a high or a low tie. Maybe there is one paper that mentioned that sometimes in older patients with a lot of arteriosclerosis, you can find a difference because the arcade are blocked. But maybe the final answer is there is no difference. And if you follow the last randomized trial published last year about this topic, you see that the level of ligation of the inferior mesenteric artery is not related to an increase of leakage. So based on leakage, from the anatomical point of view, there is no problem to transect the artery at the origin or preserve the left colic artery. Analyzing some anatomical consideration, you see that if you transect the artery, all the vascularization, the vascular supply of the colon is going to be maintained by the arc of Riolan, and also is going to be maintained by the marginal artery. So to understand that we're talking the same language, just remember that this marginal artery close to the colon is the one called the artery of Drummond. And this is important to know exactly what you do. So we mainly think that everything is based on the arc of Riolan, but this interesting study published in 2017 showed you that the arc of Riolan is only present in 18% of the patient, while the Drummond artery maintained present in 100% of the cases. So this is the basic way of maintaining the vascular supply. It doesn't matter what you do. Everything is based on the marginal artery. So it's important to manipulate and to understand where you are grasping your column to maintain this artery. In this artery, they talk about the muscopic artery that is present also only in the 11% of the cases. I've seen it sometime, but it's very, the presence of this artery is only in 11%. So what I want to mention that the most important thing is the way you manipulate the colon and where you place traction, because you can transect this Drummond artery or the marginal artery and have a problem in the postoperative period. From the anatomical point of view, also you have to have some consideration. And you can see in this video how when you go down to looking for the origin of the inferior mesenteric artery, from the anatomical point of view, it's very important to identify the nerve going to the pelvis. So you can see here all the nerve going down, and it's important not to go to clean the iliac artery and the aorta to guarantee that you are going to the origin. And it's important to make sure that you're finding the proper plane, because as you see here, some nerve is around the aorta, and that's the reason what is recommended to leave like 1 to 2 centimeters of the stump of the inferior mesenteric artery from the anatomical point of view to avoid the transection of all this net of nerve that is around the aorta. And also, another thing that you have to consider from an anatomical point of view is that if you transect the inferior mesenteric artery on the origin, you will have an extra 10 centimeters of column, which give you more chance to avoid anastomosis under tension. Another thing is the oncological consideration. Just the way this article described this oncological consideration between high tie and low tie show you that in T3 and in T4, there is a percentage of lymph node positive at the origin of the inferior artery. And that's the reason that maybe even that you consider not transecting the inferior mesenteric artery at the origin, you have to clean the fatty tissue and the lymph node of the inferior mesenteric artery in this tumor to guarantee a proper dissection of the area. Of course, those who defend that also talk about skip metastasis, and but at the end, if any positive lymph node is at the origin of the artery or around the aorta, if it's positive, it will be considered a systemic disease, difficult to control in the future. So the final answer is in some review, and especially you have this answer in this prospective randomized trial again, in which they show you that there is no difference in terms of long-term results between high tie and low tie. So high tide and low tide is not related to leakage, it's not related to survival. Maybe you have to consider to do in T3 and T4 tumor, but from my point of view, it's easy to do it as long as you preserve the nerve around the aorta and there is no impact on the results. What about the anastomosis? I told you before about side to end anastomosis. If you are having an extra column, besides having a non-tension anastomosis, I do prefer to do my colorectal anastomosis in a natural lateral side to end fashion. And the reason why I do this is because from the anatomical point of view, if you place the anvil here, by peeling this area of fatty tissue, you can have an injury of this artery. While if you place the anvil here, it's easy to preserve the vascular supply of this marginal artery, and you guarantee a better vascular supply. Even that you can have, you are going to have two lines, and they say, the people will say, you have more chance to have a leak. I prefer to do it this way. And also from a review in 2008 and a review in 2015, you have to remember that in a colorectal anastomosis with a large side to end anastomosis, you will have a better functional results. And this is the other reason why I do this type of anastomosis. But all these high tide, low tide anastomosis is important to relate it today because we feel more comfortable by performing in anastomosis because we have the possibility of performing the ICG to control the level of transection of the column. And we feel very comfortable by using this technology. We have done so far in January, we did up to January, we did almost 250 anastomosis with 102 anastomosis, 102 anastomosis of the left column. And we have to change the transection line in the left column in 23%, while in our median chain of transection line was 16%. We have to change the transection for different reasons. Like in this case, it was just for a couple of centimeters. We have to change the transection line from our original area that we decide to transect only a couple centimeters. We have some cases like this one that we need to change our transection line like around 15 centimeters from a line that it was marked at the beginning. And also we have some cases in which we have to change the transection line like around 30 centimeters because somehow we have an injury of the marginal artery. So you see that our leak rate in left column is only 1.9%. And we change the transection line in 23%. We compare this with other area of the colon, and we observe that in left colon and right and the rectum, we have more impact of the use of ICG because everything depends on this marginal artery, this artery of Drummond. And that's the reason why it's more important to use ICG in the left colon and the rectum from the anatomical point of view than using in some other area of the colon like a right column. And this is linked to the concept of the anatomical understanding of the anatomy. So just to finish, I'm just going to give you this message, and this will be my take-home message. Any surgical principle have to be linked to understanding the anatomy of the colon. And this is very, very, very important, of course, in every type of surgery, but in colorectal surgery, I would say that is even more important. Thank you very much. And I'll open to all the questions that you have at the end of the webinar. Thank you.
Thank you very much, Salva. It's again a very didactic lecture, giving all the information, the basis for colectomy. So it's very interesting. And also you mentioned the importance of having a good vascularization and the new technology that allows that. So I go back to our moderators, Madi and Nariaki, who will just show you some of the response to the survey of the different participants. So Madi,
yes,
up to you.
Yes, thank you very much. Indeed did a short survey among all our participants who are here with us today about what they do with the left colectomy. I'm going to show after every presentation one or two slides to show the relevant questions that has been asked in relation to this presentation. First, we have at the moment 300 respondents from 72 countries, and most of them are with us now live. So thank you for joining us. The age, I mean, they are in all age groups. Some are young, some are a bit less young, but it's a good representation of the surgical world. The laparoscopic sigmoid cases have been done by most of our participants. Some have a lot of experience, some have less experience. So I think the topics we are covering today are interesting for everyone. And the experience in terms of years of laparoscopic surgery, you see that most of our participants have some experience or a lot of experience. So again, I think when we see the questions, there are many interesting questions, some about the basics and some about more in-depth topics of laparoscopic surgery. So when we go to the left colic artery preservation, because I think that is one of the important questions today, is do you preserve it or not? As Professor Morales just showed us, he said in all cases it's better to take down the mesenteric artery at its root, but 60% of the participants do not do that. And we have indeed seen some scientific data showing that there is no difference whether you do a high tie or a low tie. However, just for the sake of discussion, I found an article which was from last year. It's a randomized, no, sorry, it's a systematic review and meta-analysis of the studies so far, including 24 studies, 4 randomized controlled trials, and 20 cohort studies, showing that actually the preservation of the left colic artery was associated with less anastomotic leaks, but there is no difference in oncological outcomes. So I think that's the first question for Professor Morales Conde to comment on that. What is your opinion about these data that have been presented in this study?
You want me to answer now?
Yes, sure. Go ahead.
Well, one of the things is like there is many studies about this, and different studies show different results. And some of them say that there is no difference. Some of them say there is different. What is true that today, my opinion today will be totally different. It is totally different 5 years ago. Now with the use of ICG, you have the chance to identify properly. It doesn't matter where you transect the inferior mesenteric artery, you have the answer because the ICG will help you. So I think ICG is a very, very important tool in the left column surgery because the arcade are identified with a proper vascular supply of the column. This is the first thing to say. The other thing that you have to consider is that regarding leakage, I think the manipulation of the colon is very important. It's not a question where you transect, it's the question how you manipulate the colon. By manipulating, if you preserve the arcade or not. And this is something that is totally impossible to identify in those papers, but I think this is one of the most important issues. That is the way that surgeons operate to preserve not the left colic artery, is to preserve the arcade that maintain the flow to all the left column that is going to be for the anastomosis. But today with the ICG, I feel so comfortable, and you see my data today, and you see how many transection line that I did in the change of the transection line in the left column, and this is very important data to consider the importance of this technology today from the anatomical point of view, because you know exactly what's going to happen.
Thank you, Salva. Maddie, you have question from the audience?
Yes, I do have another question from the audience. It's about the performing of the high tie, regardless of the pathology. So the question is, do you do it in oncologic resections and resections for diverticulitis?
Yeah, I do it. I do it, and I've been discussing so many times with Professor Corcioni about that. And the reason why I do it in the left column when I perform a diverticulitis, I also transect it. And this is just a personal opinion. I consider when you have a diverticulitis and you transect the colon, and the flow of the colon have to go to the splenic flexion and go down, there is more chance to maintain the same intraluminal pressure in the colon and the possibility of a recurrence. But if you have a change in the flow by mobilizing the splenic flexure, and this again, this is a personal opinion, I consider that the possibility of increasing the intraluminal pressure will be totally different. And that's the reason why I do it. So I feel more comfortable mobilizing the splenic flexure and going to the origin of the artery in these cases. I know that Professor Corcione preserve the artery just to guarantee that all the innervation of the rectum is maintained during the surgery. But what I mentioned is very, very important to perform this surgery, that you identify the proper plane, surgical plane, and you maintain all the nerve, and you identify the nerve to preserve them. And if you do that, I'm pretty sure that you're going to maintain the same results.
Okay, thank you very much. We will have time probably later at the end of this session to add some questions regarding these different topics. But time is passing, and I want to shift to our second guest speaker, who is Dr. Umberto Bracale. Dr. Umberto Bracale is used to work with Professor Corcione. They are working at the University Federico II in Napoli. So thank you very much for being with us. And he's covering a very important topic, a lot of discussion about that. Should we mobilize the left angle, the splenic angle, the splenic flexure when we're doing resection of the left colon? So thank you for being with us.
Thank you very much, Professor Dolemani. Please give me a second also to thank other people that give me this opportunity to be here today. For me, the IRCAD represents the god of surgery, so I feel like it's the first time on the moon. Thank you very much. And my presentation concern when, why, and how to perform a splenic flexure mobilization during left colectomy. So I'll speak only about left colectomy and not about anterior resection. There are in the international literature few retrospective and comparative studies that report some results about left colectomy and sigmoidectomy, but they report different conclusion and recommendation. There is only one systematic review published in 2018 that drove different and not firm conclusion. About the first questions, when I used the first paper of this first paper of Petke and colleague that concluded that as regards sigmoidectomy and hemicolectomy, it's difficult to draw a firm conclusion about the need of splenic flexure mobilization or to draw up objective criteria as to when splenic flexure mobilization should be performed. More generally, some study concluded that splenic flexure mobilization is useful in no more than 20% of cases in order to obtain a better vascularized and intention-free anastomosis. Other authors, as for example, Gilday et colleague, reported that splenic flexure mobilization in distal colectomy increased operative time without compromise overall complication or anastomotic leakage, for example, and it made add risk without significant benefit. So I would like to show you also our experience, on which, like Professor Salvatore Morales Condes, we always perform splenic flexure mobilization during left colectomy. During this left colectomy, our goal is that these steps represent the first one of a standardized surgical procedures, and with aim to detach the splenic flexure, avoiding pancreatic, splenic, and inferior mesenteric vessel lesions. So we perform a very strictly technique that aim to perform an ligation of the inferior mesenteric vein at the origin of the trites below the pancreas, and the ligation of the inferior mesenteric artery. So for vascular reasons regarding the anastomosis, we have to resect the descending colon and fully mobilize also the splenic flexure. However, we think that it's also very useful for a surgeon to be confident with splenic flexure mobilization with this step, because this step represents also the first and the crucial step for other complex procedures like splenic flexure cancer resection, also for nephrectomy and for adrenalectomy. About the second question, why we perform splenic flexure mobilization, I use again the paper of Petke and colleague that concluded that splenic flexure mobilization can provide a tension-free anastomosis with a good vascularization, and this step do not impact on immediate post-operative outcomes, despite obviously a longer operative time. There is also the EIS and SAGES 2018 consensus conference that recommend that during elective diverticular resections, the descending colon should be fully mobilized to provide sufficient colon length to form a tension-free anastomosis. It's very interesting, this anatomopathological paper about the assessing of the extent of the colon lengthening due to splenic flexure mobilization technique, on which the author performed 3 different kinds of splenic flexure mobilization. In the first 5 cases, they did not perform splenic flexure mobilization. In the second part, they perform a partial splenic flexure mobilization. And in the last part of the cadaveric models, they perform a fully mobilization. So they concluded that, that these techniques are associated to an effective lengthening of the colon, very useful for colorectal anastomosis. Our reasons are different for cancer procedures and for diverticular procedures. About the cancer procedure, I have said before that we perform a CME and a central vascular ligation. So we perform it to gain a better vascularized tension-free anastomosis. As you can see in this short video, we perform the ICG test in order to understand better where is the transection, the line of transection, and we check every time the vascularization of the anastomosis. About the diverticular disease, we perform it to obtain a specimen as wide as possible, and we have also the important statement of the Association of Colon Proctology of Great Britain and Ireland that suggests that splenic flexure should be mobilized routinely for diverticular disease resection for the same reason. About the third questions, how we perform the splenic flexure mobilization, I suggest you to read this important paper published in 2020 on surgical endoscopy, on which the author showed 5 different ways to perform a splenic flexure mobilization and to gain the epiplon retrocavity. More generally, there are in current practice 3 different ways: the anterior approach, the medial to lateral approach, and the lateral to medial approach. And in this paper, you can see that there are no different in intraoperative complication or other intraoperative data. So the 3 different approaches are very similar. I would like to show you 2 different ways that I used during my experience. The first one, when I was on my residence program in Trent with Giusto Pignata, and I was very young, and we use always an anterior approach. And as you can see, we use for splenic flexure mobilization 3 trocars, and we gain the epiplon retrocavity with the section of the Boucher lamina, and after that we go straight to the spleen, sectioning the gastrocolic ligament. So the epiplon remain attached to the colon, and we go straight to the spleen. At this point, we have to section other 2 important ligaments, the spleno-colic ligament and the phreno-colic ligament. This is probably the step more difficult, especially in fatty patients. However, we have to gain an avascular plane between the gerota and cold fascia, and so for do that, we prefer to start medially from the inferior mesenteric, from the inferior margin of the pancreas, sectioning the pancreatic colic ligament. Also, this step is not very easy in fatty patients, but as you can see from the video, we can reach this avascular plane between the cold and gerota fascia. So we take down the splenic flexure as down as possible, in order to visualize also the inferior mesenteric vein from a lateral perspective. This is very useful when we go from, and I show in another video, when we go on the inferior mesenteric vein from the trites, because all the dissection is already done. We put, after this dissection, a swab that is useful like an artificial landmark, and so we start here. We start with the section of the trites ligament, and we continue with the isolation of the inferior mesenteric vein. As you can see, we find very easy the previous dissected plane and the swab that we put before. And so we completed the dissection of the mesocolon from the inferior margin of the pancreas. As you can see, the inferior mesenteric vein and all the dissected mesocolon from the pancreas. After that, we have to isolate the inferior mesenteric vein at the origin, and it's clipped and divided. And so we go straight after that to the last, our landmark, that is the inferior mesenteric artery, that in case of cancer, we prefer to isolate it at the origin. And so we use in this video, I can show you an important landmark that is very useful to find the inferior mesenteric artery, that we isolate at its origin by ultrasound scalp. We found again in this plane the avascular plane between gerota and tall fascia. And so in a periadventitial plane, we isolated the inferior mesenteric artery, we clipped and sectioned. After that, we completed the mobilization with a parietocolic dissection, but the splenic flexure now is totally mobilized. After that, we had the lucky to start my collaboration with Professor Corcione, and I had to change totally my technique during left colectomy, because he used used 4 trocars with the first trocar in periumbilical left position, other 2 trocar in the left side, in the right side of the abdomen, and another trocar that is very useful for the assistant to make traction and contraction. So as you can see, we perform a coloepiploic detachment that is very useful because we detach all the epiplon from the colon. So at the end of the procedure, the colon is more lengthening. And so we use, as you can see, an hybrid approach. So we start the second step with the section of the muscle of triceps, and with help of the assistant, we lift up the inferior mesenteric vein, and we start gently in a implanted section to find an avascular plane between the gerotta and the told fascia. We suggest to do this dissection as far as possible, because it's very, you can see the different plane, because it's very useful for during the last step of the parietocolic detachment. After that, we have to find the artery, and so we start from another important anatomic landmark, the right iliac artery, and we go straight from the right iliac artery until the previous dissecting plane. And as you can see, it's very easy to find the inferior mesenteric artery, that it is isolated and so the last step of the splenic flexure mobilization is represented by the section of the inferior mesenteric vein, and so we open like a book the mesocolon from the pancreas, and I think that is very useful, this maneuver, because we can every time have under control the inferior port of the inferior margin of the pancreas. So it's not very easy to create to do a lesion of the pancreas. After that, we complete the dissection of the left colon with the section of the parietocolic ligament, and so as you can see in the last part of the video, that the splenic flexure is fully mobilized. I concluded with our take-home messages. First of all, I repeat that the splenic flexure mobilization during left colectomy represented very debating topic in international literature, and it is very difficult to draw firm conclusion regarding the need of splenic flexure mobilization, and to draw up some important criteria as to when splenic flexure mobilization should be performed. In our experience, we suggest to do it always as a part of very strictly standardized technique with a medial to lateral approach. Thank you very much.
Thank you very much, Roberto. It was a very interesting and again very didactic lecture. I think that it's important for this, as you mentioned, very debated topic. But what we feel is that more and more people are using this systematic splenic flexure mobilization, but we don't know exactly what is the experience all over the world. And again, I'm getting back to Maddie, who has probably some comments about that.
Yes, thank you very much. A very interesting presentation. Thank you. I have only one slide to share about the splenic flexure mobilization, because indeed it's a debatable topic. Because when we see the answers is that 65% of the world does a splenic flexure mobilization, while 35% does not. One of our colleagues who wants to have a question about that is Ashraf Al-Nazir. Could you please ask your question? Ashraf Al-Nazir? No, we cannot hear anything. All right, so we can go back to this slide where we see that 35% does not do a mobilization. And I've seen several colleagues actually that when they perform a sigmoid resection, they do the resection first, and then they decide how much length they need, and then they start with doing mobilizing in Tol's fascia. Once they reach enough length, they quit and they make their anastomosis without reaching to the splenic flexure. What is your opinion and recommendation about this approach?
Well, I explained before that as in my first experience with Giusto Pignata during my program of residency program on laparoscopic surgery, but also and more strictly with Professor Corcione, we try to apply a very standardized technique with the same steps every time in every procedures for colon cancer resection or for diverticular disease. So we prefer always to perform splenic flexure mobilization in order to avoid any kind of doubts or changing at the last of the procedures. So I know that in the international literature, there are a lot of people that prefer to check at the end of the procedure if it's necessary to do a splenic flexure mobilization. In our opinion, we think that this step probably is time consuming, but I love to have a more a well vascularized anastomosis and more tension-free anastomosis.
I have a question. What we've seen in IRCAD, because we're seeing a lot of people, a lot of colorectal surgeons, and I would say that 90% of them are using the systematic flexure mobilization. My question is regarding the timing. Is there a perfect timing? Should we start by the splenic flexure mobilization, or can we do that after mobilization of the lower part of the left colon? So is the timing important in the sequence?
I think that is very important because sometimes if you start from, for example, for the dissection of the last part of the colon of the sigmoidal, you could have the problem that in laparoscopic surgery, the sigmoidal go down, so you have some problem to expose your plane, your adequate plane, your inferior mesenteric artery. And also, I think that starting from the vein probably is more easy to find an avascular plane between Gerota and Told fascia. In fatty patients, starting from the lateral approach, I think that it could be more difficult to find a correct plane.
Salva, some comment? Salva?
No, not much. Yeah.
Sorry?
Yeah. You say about the mobilization, the
timing, you start with that. I know that you're starting with that. So
yeah.
Is it for you the rule in the process?
Yeah, the thing is, like, we are very systematic, and I like to start from the splenic flexure in all the cases. I just check the tumor or the diverticulitis if I have some doubts about the resecability, the possibility of resect the tumor. But if I have any doubts, I even check. I go directly to the splenic flexure. And as Umberto mentioned, if you sometimes there is some adhesions over the aorta from the mesenteric of one side to the mesenteric of the other side. If you start down with inferior mesenteric artery, you start going up, sometimes the left colic artery is turned a little bit because of this attachment of the mesenteric of one side to the mesenteric of the other side. By doing the splenic fracture first and dissecting the inferior mesenteric vein, you dissect that adhesions from the mesenteric of one side to another over the aorta, you free that, and when you go down and you lift the artery, it's easy to identify the origin of the inferior mesenteric artery. And that's the other reason why I start doing that.
My last question, because sometimes we can see that we have very long sigmoid loop. So even in this case, you do your routine, you do the splenic fracture.
100%.
So this is a routine. Okay. Yeah. Interesting. Thank you very much. So we're moving to the last speaker of this first day session, and it's my pleasure to welcome Dr. Lorenz Stassen. He's from the University Hospital of Maastricht, and very interestingly, is also one of the mentors of Madi, who is one of our moderators today. So Dr. Stassen, very nice to see you. I think that we know each other. And welcome to this IRCAD webinar. And we're looking forward to your lecture because it's also a very interesting topic. because I'm not a colorectal surgeon, but ureter is the main issue in colorectal surgery. So thank you for being with us.
Thank you for this kind introduction. And it's a pleasure that Madi indeed is in your famous place. I'll start sharing my screen. And indeed, it's about fluorescence imaging. It has been mentioned by the previous two speakers already, but now it's specifically about the ureter. Can we image that organ better during colorectal surgery? And the question there again is, do we have to see the ureter? Do we have to identify it or not? It's just a little bit like, do we always do the splenic flexure or not? First, a little bit of definition. There are two abbreviations, FIX and NERV, which is called fluorescence image guided surgery or near infrared fluorescence imaging. And urethral damage can occur in colorectal urological surgery in up to 8% of operations. Of course, these are the most difficult, but we want to avoid that, of course. And then in good Dutch tiles, there are surgeons that never explore the ureters because I will see them and I don't have to look for them specifically, and others always do. Why would you not want to specifically look for the ureter? Because it takes time, and especially indeed in the adipose Western patient. And there especially fluorescence imaging does help a hand because it can look through a small layer of fat more easily than our own eyes. And I'll come to that later. Here we have a short video and I want to share this with you. I hope the connection is stable enough so that you also can be enthusiastic about this image. We here see a ureter, which you only see in fluorescence imaging like this. You see the ureter, you see the peristalsis of the ureter. And in a minute we go to the right side of the patient. And then you at first don't see the ureter, and there it is again. I have to make a confession because this patient is a pig, because this was an experimental dye and experimental setting. But I'll take you through the literature in a minute. How does fluorescence imaging work? For the people amongst you that don't or are not that familiar, it uses near infrared range of wavelength, which is just out of the visible range. And the advantage is that these wavelengths are higher, larger, and thereby can penetrate a little bit through tissue and fat. There is a disadvantage of fluorescence imaging, and it is that you need special equipment. You need a dye which colors the tissue that you want to see, but you need a laser controller to excite the dye, and then you need a camera system to receive the signal that has been sent by the fluorescent dye. So you need special equipment. And you need a dye. There are some dyes which can be used already in the human being, and there are some experimental dyes coming on the market. I'll go through them with a little bit of literature, but first a little bit of explanation. Indocyanine green is a dye which is used in the human body for a long time. In colorectal surgery, you can inject it subserosely or submucosally, and it will be transported through the lymph to the liver. You can inject it intravenously, and then it will be removed by the liver and excreted in the biliary system. And this defines its imaging potential. You can see blood vessels, liver and biliary system, lymph, and its vessels. And the emission and excitation I told you a little bit about is at 800 nanometers. So you need equipment dedicated for that wavelength. Methylene blue is another dye used in the human body when injected intravenously, excreted by the liver and the kidneys. So you would be able to see the liver and the biliary system and the ureter. But it's a little bit different wavelength. So you need dedicated equipment. Then a couple of experimental dyes. Lycor is a US industry which has made the IR dye range. It can be injected intravenously, and it's again excreted by liver and kidneys. And it will be seen at the 800 nanometer wavelength. And the last one is a Dutch dye from the Leiden University, not our own university, ZW800. It's when given intravenously excreted exclusively by the kidneys, and the advantage is that there's low non-specific binding or uptake in tissues. All the other dyes have the characteristic that they not only are taken up by the target you aim at, but often also by other tissues, which deteriorates the contrast a little bit. Okay, let's see what the literature tells us about it. What dye should you choose? What technique should you choose? This is about ICG. And the confusing thing is that I just told you that it's not excreted in urine, so it should not be possible, not useful in urethral imaging. But Konishi used urethral stents, that is cystoscopy, and then insert a urethral stent and then inject the dye into that stent. Friedman and colleagues from IRCAD, they used ICG in liposomes. And what you can see is that the, I just try to, yeah, this is good, get all the faces out of the image, that all the ureters can be seen in that way quite easily. Then the next slide, which is slightly difficult. There it is. The ICG is available for human use, but it's an invasive procedure or it's experimental. So it's not a first choice procedure. Methylene blue, a couple of more manuscripts summarized in this table. I'll take you through it quickly. It can be used in a human being, methylene blue, but because of the different wavelength, you always need custom-made equipment. The commercial equipment with fluorescence capability, they do up to now not have the filter you need for the 700 nanometer. But if you have the right equipment, you can see the ureters. Although we in Maastricht, and Madi Altaher, one of your hosts of today, he did some experiments, and with our equipment, we could only see half of the ureters, or we could not see it more early than with white light. And a couple of images. This is the ureter. This is an overlay image, quite bright. This is even better. Barnes from Oxford published this in Endoscopy, but unfortunately, this equipment is not on the market. And our Storz equipment revealed these kind of images, which brings me to the conclusions for methylene blue. It's available for the human, but varying results. In some experiments, not superior to white light. There is an influence of equipment, I think. Not first choice, in my opinion. Then we move to the experimental dyes. These are promising, I think. Iodide 800 CW, which means it's equipped for the 800 nanometer range. A number of animal experiments with commercial equipment, because the commercial equipment is equipped for the 800 nanometer, and all ureters could be imaged with images like this or images like that. This is an image from the video I just showed you a couple of minutes ago. Nice pictures, I think. Iodide, okay, 800 CW. It's still experimental, not available for human use yet. Okay, we do have a commercial system, a very bright illumination, and results are consistent between centers, but it's expensive stuff. more than 500 euros per subject. ZW800 from the Leiden University. They did 2 very nice experiments, of which the last one is a phase 2 experiment in the human being. They were able to illuminate all the ureters, which you can see here. There are a couple of commercial systems mentioned. There are more. Okay, it's not yet available for human use, but at this moment, clinical trials are going on. So maybe it will be FDA approved within time. We do have commercial systems to use it. There's a bright illumination. The price up to now is unknown, which brings me to the last die I want to discuss with you from the IRCAD range. Lycor took up the challenge to make a more cheap die, and they succeeded. This die has been tested in animals because at that moment it was not for human beings yet. And again, we had very bright illumination of all ureters, which you can see here, which again means not available for human use yet, but clinical trials are going on, amongst which a large one from Oxford and one from the US. And a nice thing is that the price is exactly the price from ICG. This is 50 euros per patient. Okay, and always if there's a lot of literature, there's also a systematic review. I'll shortly discuss this with you. It's in Techniques of Coloproctology from the last year. There are a number of dyes which they and I also think are not very suitable for use because they're not better than methylene blue. The 800 dyes are better, but there is something about target to background ratio. I'll come to that in a minute. For some dyes, that seems to be disappointing. So maybe you should then not take these dyes, but go to the CW800, which has a better target to background ratio. At least that's what these authors say. And then we come to a general topic of what influences the image. A thing is dosing and time of the dye, the background signal, I explained a little bit about that, the distance and the angle of the endoscope. Let's go back, yeah, the equipment, and then the target to background ratio. That's a calculation which defines contrast between the target and the background, and that's being done by measuring the background and the target and using a computer program to do some calculations. We did a little bit of research on these topics. I'll show you something about it, and especially the target to background issue. How does that work? Well, that is a manual thing because this is the gallbladder, this is the cystic duct, that is the liver, and that is the liver. So here you can see that ICG in this case is indeed being taken up by the background, the liver. And if you want to measure the target to background ratio, the researcher has to point at the computer to measure this, to measure that, and to take the target to background ratio. But you can also use your human eye to see what is the target. And then you will clearly see the cystic duct here. And I'll give you a further example in which we used 3 preclinical dyes from the IRCAD range. Maybe you remember that in the systematic review, it was said that the CW and the BK maybe were inferior dyes, but now use your own eyes and you see a very bright illumination of the structures. Well, listeners, I hope that the internet connection was stable enough so that you could hear what I wanted to tell to you. But my final conclusions are that as a dye, the methylene blue, the CW800 and the CW are tested in a human being with especially promising results for the experimental dyes. If you read literature, be aware of the target to background ratio. That doesn't tell you all. I think it often gives an unreliable measure of performance. And fortunately, some clinical trials actually are underway. So please, all of you and us, let's unite in further research and cooperation. And indeed, I think the future of the urethra is bright. Well, thank you for your attention.
Thank you very much. Very interesting topic, very nice future as you're mentioning. I think that Maddie, who's apparently an expert in this topic with you, will look at some feedback from the audience. So Maddie.
Yes, thank you very much. A very interesting presentation, but for me, it's always interesting, but very clear to the audience as well, I think. We asked the audience one question, and I think that will please Professor Stassen. It's about whether or not they routinely check for the position of the ureter. 90% says yes, we put some effort to identify it, and I think the other 10% is now convinced. We also ask another question, and that is in general about using fluorescence imaging during surgery. 20% of the respondents said that they have used it either routinely or once in their life. So 80% still has no experience with fluorescence imaging. Now, you have shown several studies which are promising, but still not clinically available. What is your expectation of the future? When will we, and we is all the audience we are having today, will use fluorescence imaging for the identification of the ureter in routine setting?
We will do that if the dye and the equipment are very easy to use. We are surgeons, we are impatient, and we want to have all these things very easily at hand. Right now, at this moment, we don't have the right equipment for an easy dye. So if the industry would give us the equipment to use methylene blue, I think we could start tomorrow to use it. If we have to use the experimental dyes, it's up to the FDA and authorities like that. The phase 2 trials are going on now, but I think that'll take us at least 1 or 1.5 years before these dyes will be approved of. And that's a pity, because I would like to use it in a human being today.
Yes, I just would like to have the feedback from our 2 previous speakers. Salva,
yeah.
Are you going to use this method if it's on the market to complete your all fluorescence image during colectomy?
I fully agree with Lawrence that it's necessary. It will be very useful to have this technology in the OR. Even that I look for the surgical plane. I don't look for the ureter itself. I look for the surgical plane. It would be great to have the ureter illuminated to identify it. If I have the chance, I will use it. In fact, in my difficult cases, in case I have like a T4 tumor of the sigmoid, or if I have or I have to operate a patient with a diverticulitis in which there is an abscess and I cannot drain it and I have to operate them, I try to illuminate the ureter by placing a stent. I'm feeling and I feel the stent with the ICG, so I can identify. So in the difficult cases, I do illuminate the ureter with ICG. But of course, is an aggressive technology if you want to use it today, and that's the reason why I use it only in selected cases. But I would love to have it for all my cases.
Umberto, what's your opinion?
Well, I am totally agree with Salvador Morales' comment. Probably in some cases it could be very useful in diverticulitis or with huge tumor of the colon, or probably also in other kind of surgery. Normally, we have I would say a rule that we have to find correct plane between Gerota and cold fascia. So if we are in a correct plane, we check obviously the ureter, but we are sure that we are in outside of a dangerous plane.
Yeah. To summarize a little bit these different lectures today, what we understand is that colon surgery has to be very systematized. And we've seen that with the different presentation. It's really a step-by-step procedure, and we have to follow the step. And this is really the way surgery is developing today. We're trying to make it very methodic to avoid the subjective and illusion that some surgeons can have when they are checking the tension on anastomosis, when they're thinking that it's the ureter, but it's not, etc. So the tendency now in surgery is really to give to the surgeons all the tools to have something that is totally objective. And this is very important for all types of surgery. And I think that fluorescence is part of this imaging and guidance, intraoperative guidance. So I think that this lecture were very, very interesting for the audience. And I'm going back to Madi to see if there are some discussions, questions with the audience, and maybe ask some questions to the audience.
Yes, thank you very much. Out of the survey that we have done, we identified 3 questions that are particularly interesting because we see a big difference between the responses. So I would like to have a discussion about that and some recommendations from our speakers. The first question we ask is about the routine use of a drain after surgery. And the majority of our colleagues answered that they place a drain routinely, so in more than 50% of the cases. What is your recommendation and opinion about that?
Well, maybe
Okay,
Madi.
Sava?
Are we?
Yep. Regarding drain.
Yeah.
Well, I don't use drains basically in my colorectal, in my right colonic and left colonic resection. Of course, if you have a patient in which is a little bit bloody for any reason, maybe in those cases I leave a drain, but it's very selective, high selective cases. In my routine practice, I don't use drains at all in all these cases. Rectal surgery is totally different.
I think so.
Umberto?
I think so. We put the drain all in rectal low rectal resection, or in some patient that have comorbidities and that could be have some bleeding in the postoperative course. Otherwise, we don't use in colonic surgery the drain.
Lawrence?
We don't do unless we think it's necessary.
Madi?
And actually, that's only in low
Question?
anterior resections.
Madi, is there some evidence in the literature?
Yes, for sure. There's evidence, and I'm showing that in this slide, that actually all the major surgical societies do not recommend the routine use of drains because it's not shown to have any good evidence and improvement for the outcome for the patients. So the recommendation is do not use drains unless you have a good reason for that.
Excellent. Next.
So the next question is about when to start solid oral intake after the colectomy. We ask our colleagues, and you see also a variety of answers. Some start on the same day and some start after 4 days. Of course, there is also evidence about that, but I want to hear also from our experts when they start to have their patients be fed after surgery. Maybe we can start with Professor Morales-Conde.
When you talk about solid, you mean solid, not liquid, right?
Yes, solid.
Yeah, I maintain my patient the 3-4 first day and the liquid, and I send it home with liquid, with hand jelly, and I maintain my 4th first day with liquid and jelly. But I send the patient home with that diet, and they start with solid food at home. I don't trust my patient in that sense. If I tell them you can go ahead, they go ahead. And going ahead is so difficult to control. And it's just a psychological way of maintaining the patient and the control.
And what about in the Netherlands, Professor Stassen?
We listen to the patient. I always say, and I said it this morning, I listen to your belly. And if it feels good, you can have more. They have solid food at the 2nd day. We would like the 1st day, but that's often not possible.
What about Dr. Bracale?
Well, we start they start to eat on the first postoperative day normally. However, they ask to us many times when I can hit at for time in the first postoperative day. So if they would like to eat something, we start on the first one.
Okay, perfect.
Okay, so Madi, we're talking about solid, huh?
Yes, we're talking about solid, and the question is, what is solid? If it's simply to be digested, is that solid or not? Well,
Yeah, it's difficult.
exactly. But what we recommend usually patients is do not order steak for your first meal, but it's good to start
Pizza?
with bread and jam. That would be
Pizza,
okay.
it's okay.
Well, that's always delicious, and I think if a patient wants to eat pizza, that means they are in a really good shape. So there is also some evidence about that from the IRAS protocol, and I think many of us knows that. If not, then it's really highly recommended to read it, Enhanced Recovery After Surgery, which says that patients after an uncomplicated surgery can already start with intake, and that is maybe not solid at the same day, they can drink, etc. And once that is not problematic, they can gradually increase their intake on the first, second, and third day. It has also been shown that starting early feeding after surgery shows a shorter length of stay, a decreased 30-day morbidity, and overall hospital costs are also reduced. Any more comments about that?
Yeah, I have a question. We're talking about laparoscopic surgery. So sometimes maybe we still have to do some open surgery. Are the rules the same for open surgery?
If that question is to me from my limited experience, I think yes, even patient, if it's an uncomplicated surgery, if you are very happy with your anastomosis and the patient does not have a nasogastric tube drain and they're not nauseous, they can start early feeding.
Okay, our guest, what's the opinion? Salva?
Listen to the
I
patient.
don't know if you're still doing some open surgery, but sometimes.
The thing is, like in elective surgery, I've done like, I think one in the last 8 years.
Okay, so next speaker. Umberto.
Well, I think that probably patients that have laparotomic surgery feels probably ask less to eat early than laparoscopic one. This is my impression.
Okay, more difficult case also probably.
Yeah.
Lawrence?
Well, exactly the same intention in laparoscopic as in open surgery. It's the patient who decides if he or she feels good, she gets solid food, but we know that it makes a difference of about a day.
Madi? Microphone?
You can hear me now?
Yes.
Yes, I have a final question from the survey, and the rest of the questions will be discussed tomorrow. So this question was about the preferred specimen extraction site for the surgeons. And the choices we gave was through a midline incision, a phalangeal incision, or other incisions. The majority does it through a phalangeal incision, like our speakers have shown today, but still we have about 25% that do it through a midline incision. And we also saw a plethora of other potential extraction sites. Do we have a solid recommendation about what to do for these type of resections? Is a phalangeal incision better than a midline incision? Maybe we can start with Professor Delamagne.
I have no idea. To what I know is that phalangeal is probably the best, providing that you are respecting the musculature, because I can see some people doing phalangeal and cutting all the muscles, so I don't see the advantage. But if you're keeping the musculature intact, it's perfect. So I would recommend to do this phalangeal, and you can extract big specimen. But I'm not doing that much colorectal surgery as I was mentioning, so probably Salva is a better idea.
Yeah, I fully agree with you, because if you go through the literature, all the recommendations say that the phalangeal incision have less percentage of incisional hernia. And even if you have an infection of the incision, is well tolerated in terms like infection take you to incisional hernia, and in a fan steel incision, it doesn't goes that far. And on the other hand, I agree with you with the concept of not transecting the muscle, not transecting the muscle.
Okay. Umberto?
Yes, I am agree. We use routinely the final incision without the transection of the muscles, not only for colorectal surgery, but also for other kind of surgery, for gastric surgery. More generally, we think that it's best site for specimen extraction.
Lorenz?
I agree completely to Dr. Morales' comment. I cannot say it better. Even the infection, that's perfectly right. Van der Stiel.
Okay, I have another question, because with Joël Leroy in the past here in IRCAD, we were looking a little bit at the natural extraction of the specimen through the colon sometimes, or through the vagina. So do you have some ideas, recommendation, or contraindication for that? What's your opinion about that? Salva?
I've done several cases of transvaginal and transrectum remove of a specimen. I have experience. In transvaginal works perfectly because you introduce a bag, you pull it and you close it. I start closing it through the abdomen, and now I learned how to close it through the vagina, and an easy task. But on the rectum, I did some cases, and I mean, you feel a little bit uncomfortable of dilating too much the rectum, and that's the reason why I stopped doing that. And I did it just in cases in which a specimen was very, very small or very thin, let's say in thin patient.
Umberto?
We had an experience with the vaginal extraction, and I think that I can suggest you to do not use it when you have, for example, an anastomosis very close to the line of transection of the vagina, because we had some problem with the colovagina fistula. So I think that we suggest this.
Yeah. Lorenz?
No, actually we don't, because we have such good experience with the Van der Stiel, and I think it's very difficult to beat these advantages.
Yeah, I think that probably the direction is that maybe in some very specific case you can use this natural orifice extraction, but it's not the basic recommendation. I don't know, Madi, if you have some ideas about that in terms of the literature.
Well, I find some evidence from the literature. It's not about the natural orifice extractions, but Van der Stiel versus midline. And in general, there is not a preferred extraction site. However, there is more and more evidence saying that a Van der Stiel incision is preferred because it has less midline incisions.
Okay. So, Madi, do you have some question from the participants?
Well, actually, we have many questions. Most of them have been answered, and I see also many participants who really congratulate the speakers for their excellent presentations. We have some questions about ICG for the use of the anastomosis, but that is a topic that's going to be discussed tomorrow. Okay. So I think most of the questions have been covered today.
Okay, so it's perfect because timing is on schedule. So I would like to thank you, of course, all the participants who joined us. There were about more than 300 people, if I'm right. So it's a good audience. And thanks to this expert that we have today, because these participants stay all the way through the webinar, so it's a good sign. So thank you for the quality of your speech. As I was saying, this is a 2-day session. So tomorrow, same time, we will repeat the process, and with different topics. We have topics on the stenting for obstructing cancer. We have again a topic on fluorescence, and finally we will talk a little bit about the role of robotic in this left colectomy. So thanks again to the participants. Thanks again to the experts. So Salva, go back to the beach. And I'm looking forward to see you, hopefully, back here in IRCAD, and we can develop some tactile feelings together. Thank you very much for being with us, and thank you for the participants. Bye-bye.
Thank you. Pleasure.
Thank you. Bye.
Bye-bye.